Welcome to Weekly Neurology Deep Dive, your go-to resource for staying up to date on all things neurology. This show is strictly for educational purposes and doesn't have any commercial affiliations. This week, we're going to really dig deep into a recent paper on neurogenic orthostatic hypotension, that is in Parkinson's disease. Specifically, we're going to focus on what you really need to know for your clinical practice. Now, before we get started, just a reminder that this is just a quick overview, so we strongly encourage you to check out the full paper for all the details.
Absolutely. And this paper really gets into some of those practical aspects of NOH that, well, we encounter every day with our patients,
For sure. Now, one thing the authors really drive home right off the bat is just how impactful NOH is for our patients with Parkinson's. They're not overstating it when they say it can be really significant.
Not at all. It affects something like 30% of Parkinson's patients. And, the paper brings up some, well, pretty serious data, the risk of falls, higher chances of hospitalization, and they even suggest a possible link to mortality.
Yeah, those hospitalization numbers really jumped out at me, too. They cite a study showing a 285% increase in hospitalization days and a 152% jump in ER visits for Parkinson's patients who also have orthostatic hypotension.
You can't really argue with those numbers. I mean, this is a serious problem that affects not just our patients' quality of life, but also healthcare costs, and pretty significantly, too.
Absolutely.
Yeah.
So definitely something we need to be on top of. Now, diagnosing NOH, well, it's not as simple as it might seem at first, right?
You got it. The symptoms, they can overlap with other blood pressure issues that we often see in Parkinson's, and that can make it really tricky to zero in on. They talk about traditional diagnostic methods like the active standing test and the tilt table test.
The classics, right? Every neurologist go to. But it sounds like those might not always give us the whole picture.
Right. They can miss those more subtle, intermittent drops in blood pressure that some patients experience. And that's where this new metric, the ARU-EAGP ratio, comes in.
To be honest, that's a new one for me. Could you break it down for us? What does it tell us, and why should neurologists care?
Basically, it compares the change in heart rate to the change in systolic blood pressure when a patient goes from sitting to standing. When that ratio is small, like specifically under 0.49, it's a strong indication of NOH. And the Kaufman study that they cite found it to be incredibly accurate, 91.3% sensitive and 88.4% specific, in fact.
That's really impressive, especially for just a single metric. I'm curious, how does this change how we approach diagnosing NOH?
Well, it gives us this really reliable tool for differentiating NOH from other types of orthostatic hypotension. Just imagine. You can confidently rule in or out NOH based on a simple calculation. It could dramatically change our diagnostic process, which ultimately leads to more targeted treatments for our patients.
Sounds like it could streamline things quite a bit, but the paper also stresses that a thorough assessment is still key. They talk about ambulatory blood pressure measurement, or ABPM, for short.
Definitely. ABPM gives us that continuous 24/7 view of the patient's blood pressure, capturing those ups and downs that we might miss during a regular office visit.
They even mention something as simple as a patient diary to help interpret the ABPM data. Old school, but effective.
It's all about context, right? A diary helps us understand if those blood pressure changes happen after meals, after taking medication, or if the patient had any specific symptoms at that time. Those details can be crucial for putting the puzzle together.
Connecting the dots, absolutely. Now, one area I know a lot of neurologists are curious about is wearables. Does this paper shed any light on how those devices might change how we manage NOH?
It does, and this is where things get pretty interesting. The paper suggests that wearables like smartwatches, they have the potential to really change the game in NOH monitoring.
So continuous monitoring throughout the day, not just those isolated readings in the office.
Exactly. Imagine tracking a patient's blood pressure in real time. We could catch those intermittent dips that we'd normally miss and be much more proactive in how we manage their condition.
So we'd be talking about adjusting medications, making lifestyle recommendations, maybe even preventing falls before they happen. Sounds like a whole new world for patient care.
It could be.
But I'm sure there are some hurdles with this type of technology, right?
Of course. The biggest ones are accuracy and standardization. We need more research to validate these devices for Parkinson's patients specifically. We need to be certain that the data they're collecting is reliable and clinically meaningful.
And not all wearables are created equal. There are tons of different devices out there, so we'd need clear guidelines on how to interpret that data.
I agree. It's still early, but the potential is massive. It could really change how we diagnose and manage NOH moving forward.
Exciting times. Now, let's talk about another key area for neurologists, medication. The paper points out how many common medications can actually make NOH worse. It's crucial info for us as prescribers.
For sure. We need to be aware of this with every patient. We're talking diuretics, alpha blockers, tricyclic antidepressants. A lot of our patients are taking these for other conditions.
And even levodopa, the mainstay of Parkinson's treatment, can contribute to the problem.
Right. While we're still figuring out the exact mechanisms, it seems that levodopa can affect the baroreflex, the system that keeps blood pressure stable when we change positions.
So it's this balancing act. We're trying to manage the Parkinson's effectively, but also need to watch for these blood pressure side effects.
We've got it. And that's where this paper provides some really helpful guidance. It offers a great overview of those medications that can worsen NOH and some practical strategies for minimizing those effects.
It's all about making informed decisions, weighing the risks and benefits for every patient. Now, the paper also gets into this phenomenon called hypotension unawareness. That was a really interesting point for me.
Yeah, it's a critical concept for neurologists. Essentially, some patients just don't experience the typical NOH symptoms like the dizziness or lightheadedness, even when their blood pressure drops a lot.
No warning signs, just a sudden fall. That's pretty frightening.
It is, and the paper mentions research that shows there's actually no correlation between how much the blood pressure drops and whether the patient has any symptoms.
So we can't rely on patients reporting dizziness as a reliable indicator for NOH. What does that mean for us in the clinic?
It means we have to be vigilant. We need to actively screen for NOH in all our Parkinson's patients, even those who aren't reporting those classic symptoms.
So detailed history, thorough neurological exam, and using tools like ABPM to really understand those blood pressure patterns.
You got it. Being proactive is key, especially when you consider the potential consequences of leaving NOH undiagnosed and untreated.
Now, this is where the paper shifts gears a bit and delves into the physiology behind NOH. What's happening in the brain that's causing all of this?
Well, it all ties back to that core issue in Parkinson's, the loss of dopaminergic neurons. And it's not just about movement, This neuronal loss affects the autonomic nervous system, which controls things like heart rate and, blood pressure.
So it's disrupting both the sympathetic and parasympathetic nervous systems. How does this lead to the symptoms we see with NOH?
It causes a decrease in norepinephrine release, a neurotransmitter that plays a big role in vasoconstriction. That's the narrowing of blood vessels that helps regulate blood pressure.
So if you think about a healthy person, when they stand up, their blood vessels constrict to keep their blood pressure steady. But in someone with NOH, that system isn't working right.
Exactly. The blood vessels don't constrict enough, their heart rate might not increase enough to compensate, and that leads to that sudden drop in blood pressure when they stand.
And that explains all those symptoms we see, the dizziness, the lightheadedness, and sometimes even the falls. It all makes sense. Now, this brings us to the part I think every neurologist is waiting for. What can we actually do about NOH? What treatment options does the paper discuss?
Well, the good news is we've got options. We have both non-pharmacological and pharmacological approaches, and that's important because there's no one-size-fits-all solution to NOH.
Let's start with those non-drug strategies. What are some simple things we can tell our patients to do at home to help manage their NOH?
Patient education is key here. We've got to help our patients understand what triggers their NOH, things like hot baths, big meals, alcohol, standing for long periods, and then empower them to avoid or adjust those triggers.
Small changes can make a big difference. And what about those physical countermaneuvers we talked about earlier?
Those can be surprisingly effective. Things like crossing your legs while you're standing, squatting down if you feel lightheaded, or even just tensing your leg muscles. They all help increase blood flow back up to the heart.
And of course, we can't forget exercise. It's so important for everyone, especially those with Parkinson's. Does the paper address that at all?
It does. And they emphasize that the type of exercise matters. High-intensity stuff with a lot of up and down movement can actually make OH worse. They suggest activities like recumbent cycling or rowing, things that are gentler on the cardiovascular system.
So tailoring those recommendations to the individual. And then there are things like compression stockings and abdominal binders, which can be helpful for some.
Yep, those can help improve venous return, basically helping squeeze the blood back up from the legs towards the heart. But, practicality is key. Some patients might struggle with stockings, especially if they have mobility issues, so abdominal binders might be a better fit.
So plenty of non-drug options to consider. Now let's dive into those medications we might use for NOH. The paper spends a lot of time discussing droxidopa and midodrine. Tell us about those.
Those are the big guns, so to speak, the mainstay treatments for NOH right now. Droxidopa is a prodrug that converts to norepinephrine in the body. So it's basically boosting those levels, which helps raise blood pressure.
Addressing that norepinephrine deficiency directly.
Exactly. And then there's midodrine, which is an alpha-1 adrenergic agonist. It works by directly stimulating the receptors in the blood vessels, causing them to constrict and raise blood pressure.
They both sound pretty straightforward in terms of how they work. But with any medication, we need to be thinking about those potential side effects, right? What are some of the things we should be watching out for?
With droxidopa, the most common ones are headache, dizziness, nausea, and fatigue. And with midodrine, the big one is supine hypertension, which is an increase in blood pressure when lying down. So timing that dose is really important. We want to avoid it kicking in when the patient is lying down.
Makes sense. The paper also talks about fludrocortisone, which I know some neurologists use for NOH, even though it's off-label.
Yeah, fludrocortisone is a synthetic mineralocorticoid, basically helping the body hold on to salt and water, which increases blood volume. It can be effective, but it has a lot of potential side effects like edema, hypokalemia, even hypertension, so it's not a first-line choice.
And the research on its effectiveness in the long run is pretty limited. So we've got our main players, droxidopa, midodrine, and fludrocortisone. But the paper mentions some newer therapies too, like norepinephrine transporter inhibitors or NET inhibitors.
That's right. These work by blocking the reuptake of norepinephrine, so there's more of it available to do its job.
Atomoxetine and reboxetine are a couple examples, right?
Yeah.
What's the evidence like for those in treating NOH?
Well, there have been some encouraging early studies, particularly with atomoxetine, that show improvements in orthostatic blood pressure.
But it sounds like we need more research to confirm if they're really effective and safe in the long term before we start recommending them for all our patients.
Absolutely. But it's a promising area to watch. The treatment landscape for NOH is constantly evolving. I think we're going to see some big advancements in the coming years.
It's a great time to be a neurologist, that's for sure. Now, the paper gets into a really complex issue here. Managing NOH in patients who also have those other blood pressure problems that are common with Parkinson's. We talked about supine hypertension a bit earlier, but they also discussed nocturnal hypertension and non-dipping hypertension. What exactly are those, and why should neurologists be concerned about them?
Basically, these are conditions where the blood pressure doesn't behave the way it should at certain times of day. Supine hypertension is high blood pressure when lying down. Nocturnal hypertension is high blood pressure at night. And non-dipping means the blood pressure doesn't have that normal dip at night that we see in healthy folks.
So we've got high blood pressure when lying down, high blood pressure at night, and no dip at night. It sounds like a perfect storm for cardiovascular problems.
It definitely raises the risk of those kinds of issues for sure. And it makes managing NOH even more complicated because what we do to address the low blood pressure upon standing can sometimes make these other problems worse.
It's a tough balancing act, trying to get that blood pressure just right, managing the NOH without setting it too high at other times. What strategies can we use to handle this complex situation?
Well, as always, we start with non-pharmacological approaches. Elevating the head of the bed, avoiding salty snacks before bed, staying well hydrated. Those simple things can be surprisingly effective.
And for those who need more than lifestyle changes,
Then we've got to be very careful about which medications we choose and when we give them. Timing is everything. Like we talked about earlier, if someone's taking midodrine for NOH, we don't want to give it too close to bedtime because that could worsen their supine hypertension.
so it's about understanding the ins and outs of each medication, their potential side effects, and how they might interact with other drugs the patient might be taking.
Exactly. It's not just about managing NOH in a vacuum, it's about looking at the whole patient, their entire health picture.
And that brings us back to monitoring. We've talked a lot about ABPM, but are there other ways to monitor these patients that might be helpful?
ABPM is definitely the gold standard for getting that full picture of blood pressure patterns throughout the day. But like we said earlier, even something as simple as a patient diary can be really valuable. It helps us link those blood pressure changes to specific things, events, activities, giving us more context for understanding those numbers.
It's about empowering the patient to take ownership of their condition, to help them understand their own blood pressure and what might be triggering those changes.
Exactly. It's a collaboration, the patient and the neurologist working together.
Now, I want to touch on something that really caught my eye. The research frontier of NOH. This paper points to some areas where our knowledge is still evolving. What are some of the key questions that researchers are trying to answer right now?
One of the big ones is the exact mechanism of how levodopa, which is, our go-to treatment for Parkinson's, contributes to OH. We know it plays a role, but we're still debating the details.
The paper mentions things like vasodilation and effects on the baroflex, but clearly we need more research to really untangle that relationship.
We do. And then there's the question of why some patients develop NOH and others don't. Is there a genetic component? Are there specific lifestyle factors involved? Those are all areas where we need more data.
And of course, there's the constant search for new and improved treatments. The paper mentions some promising avenues, like those norepinephrine transporter inhibitors, but we need more clinical trials to really know if they're effective and safe.
Exactly. And we need to be open to new ideas, too. Are there non-drug approaches we haven't explored fully? Can we use technology to manage NOH better? There are a lot of exciting possibilities out there.
It's a dynamic field for sure. I can't wait to see what breakthroughs come out in the next few years. Now, before we move on to the next part of our discussion, I want to loop back to one of the most interesting points in this paper, the potential connection between NOH and cognitive decline.
Yeah, this is a really important area that we can't ignore. Like we discussed earlier, the idea is that this chronic cerebral hypoperfusion, all those repeated drops in blood flow to the brain caused by NOH, could be damaging over time and lead to cognitive problems.
And the research seems to back that up. A number of studies have shown a link between NOH and a higher risk of dementia in Parkinson's patients. This really changes how we need to think about managing NOH, doesn't it?
Absolutely. We need to be proactive, identify those patients early on, and manage their NOH effectively. And we need to talk frankly with our patients about the risks to their cognitive function and encourage them to let us know if they're noticing any changes.
Early detection and early intervention, absolutely crucial. We can't wait until those cognitive problems are really obvious before we start taking action.
Exactly. We need to think long-term here, not just about managing immediate symptoms, but about protecting our patients' brains.
And that brings us to the heart of this paper, doesn't it? The need for a real shift in how we approach NOH. It's not just about getting those blood pressure numbers to look good. It's about understanding that complex interplay between NOH, Parkinson's, and cognitive function. It's about taking a holistic approach to caring for our patients.
I couldn't agree more. This paper is a fantastic resource for neurologists. It highlights how important it is to do a thorough assessment, create individualized treatment plans, and really monitor our patients closely. It's a must-read for anyone who works with Parkinson's patients.
Absolutely. Well, I think this is a great place to pause for now. We've covered a ton of ground in this first part of our deep dive into NOH. We talked about its impact, the challenges of diagnosis, the interplay between medications and lifestyle factors, and that potential link to cognitive decline.
And we've touched on some really interesting new developments too, like that 8-RT-BP ratio and the potential for wearables to change how we manage NOH.
There's a lot to take in, so we encourage you to take some time to reflect on what we've discussed so far.
Welcome back to Weekly Neurology Deep Dive. Last time we laid the groundwork, exploring how important NOH is in Parkinson's and the challenges we face in diagnosing and managing it.
Now we're going to dig deeper into the specifics of managing NOH. One thing that really stood out to me in this paper is how they emphasize looking beyond just those blood pressure numbers when we're trying to figure out if a treatment is working.
I think that's a really important point. It's easy to get fixated on those numbers, but we got to remember, numbers don't always tell the whole story.
Right. It's about how the patient is actually feeling, how they're functioning in their day-to-day lives. Are they still dizzy? Are they afraid to stand up because they might faint? Are they limiting their activities because of NOH? Those are the things that really matter.
Absolutely. We need to shift our focus. It's not just about getting those blood pressure numbers to a certain target. It's about actually improving the patient's quality of life. And that means listening to them, understanding what they need and what their goals are, and then tailoring our treatment plan to fit those needs.
It's a partnership, working with the patient to find the best approach. Now, before we get too deep into treatment strategies, I want to circle back to something we touched on earlier. Those Parkinson plus syndromes, they can be really tough to diagnose, even for experienced neurologists. Does this paper give us any insights into how NOH can help us differentiate between these conditions?
It does. The authors point out that the way NOH presents, the pattern of it, can give us some valuable clues. It can help us distinguish between straight Parkinson's disease and those atypical Parkinsonian syndromes, things like multiple system atrophy or MSA and progressive supranuclear palsy or PSP.
So can you give us an example of how this might work in practice?
Sure. Let's take MSA. In MSA, NOH often shows up much earlier in the course of the disease, and it tends to be much more severe than what we typically see in Parkinson's.
So if we see a patient who has early onset NOH and it's really severe, that should raise a red flag for MSA.
Exactly. And if that NOH is coupled with other symptoms like urinary incontinence or problems with coordination, those cerebellar signs, then our suspicion for MSA goes up even more.
So it's not just about recognizing that NOH is present, it's about understanding the specifics of how it presents, what those nuances might tell us about what's really going on.
Precisely. It's another tool in our toolbox, helping us make those critical distinctions that can guide treatment decisions and ultimately lead to better outcomes for our patients.
It's all about connecting the dots. Now, I want to switch gears a bit and talk about something that I think has the potential to really change how we manage NOH wearable technology. We
Yeah.
mentioned it briefly before, but I think it deserves a closer look.
I agree. It's a really exciting area with so much potential. Just imagine being able to track our patient's blood pressure 24/7 throughout the day and night using a simple smartwatch.
It would give us so much more information. We'd be able to see those blood pressure swings that happen outside of the office, things we'd normally miss.
Exactly. And it's not just blood pressure. Some of these wearables can track heart rate variability too, which gives us a window into how well the autonomic nervous system is working.
That's incredibly valuable information. We could really fine-tune treatment plans and maybe even head off problems before they start.
The possibilities are pretty amazing. We could adjust medications, make lifestyle recommendations, even use it as a motivational tool to encourage patients to make healthy changes.
It could totally change how we manage NOH. Instead of just reacting to problems, we could be proactive, preventing them from happening in the first place. But of course, with any new technology, there are going to be some challenges.
Of course, accuracy and reliability are the big ones. We need to be sure that the data these devices are collecting is accurate and actually means something clinically. And then there's the issue of standardization. There are so many different wearables out there. We need clear guidelines for interpreting the data from all these different devices.
It's early days for wearables and NOH management, but the potential is huge. I'm really excited to see how this technology develops over the next few years and how it shapes neurology as a field.
I agree. It has the potential to be a real game changer. Now, switching gears again, this paper really got me thinking about a particularly tricky part of managing NOH, dealing with it when patients also have other blood pressure problems.
We touched on this earlier, but it's so common in practice that it's worth revisiting. We're talking about supine hypertension, nocturnal hypertension, non-dipping hypertension. Trying to manage that low blood pressure when they stand up, but also making sure their blood pressure doesn't go through the roof at other times. It can feel like a losing battle sometimes.
It's definitely a balancing act, and it requires a multi-pronged approach. Lifestyle modifications, careful medication choices, and close monitoring. Those are the three pillars.
Let's break each of those down a little bit. What are some of the key lifestyle changes we should be discussing with our patients?
Well, we've talked about some of the basics already, things like raising the head of the bed, avoiding salty snacks at night, making sure they're drinking enough fluids. But we should also be encouraging regular exercise as long as it's appropriate for that individual patient. Exercise is good for cardiovascular health in general, and that can have a positive impact on blood pressure regulation.
And what about diet? Does the paper mention any specific dietary recommendations?
They emphasize the importance of a balanced diet, low in sodium, plenty of fruits and vegetables, whole grains. That kind of diet can help lower blood pressure overall, and it might be especially helpful for patients who have both NOH and other blood pressure issues.
So it's really about promoting healthy habits that support good cardiovascular health in general. Now, let's talk about medications. What are some of the key things we need to keep in mind when prescribing meds for NOH in patients who also have these other blood pressure problems?
The timing of the doses is absolutely critical. Like we said before, if a patient is taking midodrine for NOH, we don't want to give it too close to bedtime. That can make their supine hypertension worse.
So being really strategic about when those medications are given to get the best effect and minimize the side effects.
Exactly. And we also need to be aware of potential drug interactions. A lot of our patients are on multiple medications for various conditions, and we need to understand how those drugs might interact with each other and how those interactions could affect blood pressure.
It's about looking at the whole picture, making sure all the pieces of their medication puzzle are fitting together.
That's right. It's not just about managing the NOH in isolation. It's about managing it as part of the patient's overall health.
And that brings us to that third part of our management strategy, monitoring. We've talked a lot about ABPM, but are there other monitoring tools that might be useful in these patients?
ABPM is definitely the gold standard for getting a complete picture of how their blood pressure is behaving throughout the day. But, like we said earlier, even a simple patient diary can be incredibly helpful. It lets us connect those changes in blood pressure to specific things that are happening, which gives us much more context.
It gives the patient a more active role in their own care, too, helping them understand their blood pressure patterns and learn to recognize those triggers.
It's about working together, the patient and the doctor, as a team. Now, I want to talk a little bit about the cutting edge of NOH research. The paper highlights some areas where our understanding is still evolving. What are some of the key questions that researchers are wrestling with right now?
Well, one of the big mysteries is exactly how levodopa, the cornerstone of Parkinson's treatment, causes OH. We know it does, but the specifics are still unclear.
The paper talks about vasodilation and effects on the baroflex, but we definitely need more research to fully understand that whole relationship.
And then there's the question of why some patients develop NOH and others don't. Is there something genetic going on, or are there particular lifestyle factors involved? We need more data to figure that out.
And of course, we're always looking for new and better treatments. The paper mentions some promising therapies like those norepinephrine transporter inhibitors, but we need more clinical trials to really know how well they work and if they're safe to use long term.
It's exciting to see these new possibilities emerging. It gives us hope for those patients who haven't found relief with the treatments we have now.
Definitely. And research in NOH is moving forward all the time. We're learning more about the mechanisms involved, identifying new targets for drug development, and exploring some innovative treatment approaches.
It's a really dynamic field. I can't wait to see what breakthroughs we'll see in the next few years. Now, before we wrap up this part, I want to bring up that idea, a potential link between NOH and cognitive decline.
This is such an important area that we can't afford to ignore it. As we talked about before, the thinking is that those repeated dips in blood flow to the brain that happen with NOH, that chronic cerebral hypoperfusion, it could be causing damage over time and contributing to cognitive problems.
And the research is starting to point in that direction. We've seen a number of studies showing a correlation between NOH and a higher risk of dementia in patients with Parkinson's. That really changes how we need to think about managing this condition, doesn't it?
Absolutely. We have to be proactive. We need to find those patients early on and manage their NOH effectively. And we need to be straight up with our patients about the potential cognitive risks and make sure they understand to let us know if they notice any changes in their thinking.
Early detection is key. Early intervention is key. We can't wait until their cognitive function has already started to decline before we do something.
That's right. We have to think about the long game, not just managing their symptoms right now, but protecting their brains for the future.
And that leads us to the main message of this paper. We need to change how we think about and manage NOH. It's not just about getting those blood pressure readings to look good on paper. It's about understanding how NOH, Parkinson's disease, and cognitive function all connect. It's about taking a holistic approach to caring for our patients.
I completely agree. This paper lays it all out for neurologists. It shows us how important it is to do a really thorough assessment, create a treatment plan that's tailored to each patient, and monitor those patients closely. It's a must-read for anyone who works with Parkinson's patients.
I agree. Well, I think this is a good place to take a break. We've covered a lot of ground in this second part of our deep dive into NOH. We've talked about managing it in patients who have other blood pressure problems, explored the potential of wearables, and delved into some of the exciting research that's going on in this field. Welcome back to Weekly Neurology Deep Dive. We've covered a lot of ground in this deep dive into neurogenic orthostatic hypotension in Parkinson's disease, but we've still got more to explore.
In this final part, we're going to get into the nitty-gritty of treatment strategies, talk about some of those emerging technologies, and leave you with some food for thought, some things to consider as you're working with your patients.
The paper does a great job of laying out a bunch of different ways to manage NOH, both with and without medications. It can be a little overwhelming, even for those of us who've been doing this for a while, trying to sort through all these options. Where do we even start?
I think that's where that personalized approach that we've been talking about throughout this whole deep dive is really crucial. There's no magic bullet, no one-size-fits-all solution. The best treatment is going to be different for every patient, depending on their individual symptoms, their overall health, what they're comfortable with.
So understanding each patient's specific situation and tailoring our approach to fit them.
Exactly. Let's start by going back to those non-drug strategies we discussed earlier. Those are often our first line of defense, and they can be surprisingly effective for a lot of patients.
We talked about simple lifestyle modifications, things like elevating the head of the bed, cutting back on salty snacks, especially close to bedtime, staying well hydrated. Those are easy things to do, but they can have a big impact.
And those physical countermaneuvers are important too. Teaching our patients to cross their legs when they're standing or to squat down if they feel faint, those techniques can help them manage those symptoms on the spot and prevent falls.
And of course, exercise. It's good for everyone, but it's especially important for people with Parkinson's. We need to make sure our patients are staying active as long as it's safe for them.
Absolutely. But like we said before, the type of exercise makes a difference. Intense workouts, lots of up and down movements, that can actually make OH worse. So we need to guide our patients towards activities that are appropriate for their situation, things like recumbent cycling or rowing.
Finding that balance, staying active without making the NOH worse.
Exactly. And then there are things like compression stockings and abdominal binders. Those can be helpful for some patients by improving that venous return, helping the blood get back to the heart from the legs. But we always have to think about practicality. Are those things realistic for our patients? Are they going to be able to use them consistently? If someone has trouble with mobility, for example, stockings might not be the best choice. Maybe an abdominal binder would be a better fit.
It's all about finding solutions that actually work in the patient's real life, something they can stick with.
Right. Now, for some patients, lifestyle changes alone aren't enough to control their NOH. That's when we start thinking about medications. We talked about the main ones: droxidopa, midodrine, fludrocortisone. Each one works a little differently. They have different pros and cons and different potential side effects.
Let's break those down a bit more. What are the key things to consider for each medication?
Sure. Droxidopa, that's a prodrug that turns into norepinephrine in the body. It basically bumps up those norepinephrine levels, which helps raise blood pressure. It's usually pretty well tolerated, but some common side effects are headache, dizziness, nausea, and fatigue.
And midodrine.
Midodrine, that's an alpha-1 adrenergic agonist. It works by stimulating those receptors in the blood vessels directly, causing them to constrict, and that raises blood pressure. The big thing to watch out for with midodrine is supine hypertension, that rise in blood pressure when they're lying down. So timing that dose is really, really important.
And what about fludrocortisone?
Fludrocortisone is a synthetic mineralocorticoid. It helps the body hold on to salt and water, which increases the volume of blood. It can be effective, but it does carry a higher risk of side effects, things like edema, low potassium, and even high blood pressure. So it's not usually our first choice.
So each one has its pluses and minuses. It's about weighing those carefully when we're making decisions for our patients. What else should we be thinking about?
We always have to consider the patient's overall health, other medications they're taking, what their preferences are. Some patients might be more concerned about side effects, even if it means the medication might not be quite as effective. Others might be more focused on getting the best possible symptom control, even if there's a slightly higher risk of side effects.
It's about communication, having that open dialogue with our patients and figuring out the best option together.
Exactly. Now, beyond those well-established medications, the paper does touch on some newer therapies for NOH. Remember those norepinephrine transporter inhibitors or NET inhibitors we talked about earlier?
And amoxicillin and reboxetine, right?
Yep, those are the ones. And the early research on those has been pretty promising. Atomoxetine especially has shown some good results in terms of improving orthostatic blood pressure. But we do need more research, more long-term data to confirm that they're safe and effective before we start using them routinely.
It's exciting, though, to see those new options coming down the pipeline. It gives us hope for patients who haven't had success with other treatments.
Absolutely. And the research in this area is moving so fast. We're learning more about how NOH works, identifying new targets for medications, and exploring some really innovative treatment approaches.
It's a great time to be a neurologist, that's for sure. Now, before we wrap things up, I want to shift gears for a minute and talk about that idea of wearables revolutionizing NOH management. We've been circling back to that throughout our conversation.
I think it's an area with huge potential. Like we've been saying, wearables could give us that continuous blood pressure monitoring all day and all night, catching those fluctuations that we miss with our traditional methods.
We could identify those triggers,
Yeah.
maybe adjust medications before a problem even develops, even prevent falls.
And some of these devices can track other things too, like heart rate variability, which can give us really useful information about how well the autonomic nervous system is working.
It really could be a whole new way of approaching NOH, a shift from reacting to problems to actually preventing them. But of course, there are some challenges to overcome.
Definitely. Accuracy and reliability are at the top of the list. That data these devices are collecting has to be accurate and clinically meaningful. And then there's the issue of standardization. There are so many different devices out there. We need clear guidelines for interpreting the data from each one.
And of course, there are privacy issues to consider. We need to make sure our patients are comfortable with that level of monitoring.
But I'm optimistic. I think as technology keeps advancing, those challenges will be addressed. I really think wearables have the potential to fundamentally change how we manage NOH, empowering patients and giving us the information we need to provide more personalized, proactive care.
So we've come to the end of our deep dive into neurogenic orthostatic hypotension in Parkinson's disease. We've explored how important this condition is, the challenges involved in diagnosing and managing it, and all those different treatment options that are available.
We've talked about approaches with and without medications. We've dug into some of the latest research and explored the exciting possibilities of wearable technology.
But remember, this is just the tip of the iceberg. We encourage you to go read the full paper, check out some of those resources we mentioned, and keep learning about this fascinating and evolving area of neurology.
And most importantly, use this knowledge to make a difference in the lives of your patients who are living with NOH.
Thanks for joining us on this journey. Until next time, keep those brains buzzing.
And keep diving deep.